Today I will discuss another two members from herpes virus family. They are Cytomegalovirus and Epstein Barr virus. Let's have a quick recap of what we discussed last time. Herpes simplex virus and varicella zoster virus, both of these are going to produce a vesicular rash. Herpes simplex virus, varicella zoster virus and cytomegalovirus, all of these are going to produce multinucleated giant cells. In biological classification, we discussed about cytomegalovirus, which is included in beta family, and it can infect T lymphocytes and glands, whereas Epstein Barr virus is included in gamma family and it can become latent in B lymphocytes and lymphoid tissue. All of these members are DNA and envelope viruses. Structurally and morphologically, these are similar to other herpes viruses, but they are antigenically different. I will discuss modes of transmission, pathogenesis, clinical features, and laboratory diagnosis of cytomegalovirus and Epstein Barr virus. Let's first discuss cytomegalovirus. There are various modes of transmission of cytomegalovirus. Early in life, it is transmitted across the placenta, within the birth canal, and quite commonly in breast milk. In young children, it's the most common mode of transmission, and that is through saliva. Later in life, it is transmitted sexually and is present both in semen and cervical secretions. It can also be transmitted during organ transplants and blood transfusions. Pathogenesis of cytomegalovirus. Normally, antigen, which is a virus in this case, is processed through antigen presenting cell after being taken up, and then it is presented with the help of MHC type 1 complex. This MHC stands for major histocompatibility complex. This activates cytotoxic T lymphocytes or CD8 T lymphocytes. In case of cytomegalovirus, there is a specific mechanism of immune evasion that allows it to maintain the latent state for long periods. In cytomegalovirus infected cells, assembly of the MHC class 1 viral peptide component is unstable, so viral antigens are not displayed on the cell surface. So there would be no killing by cytotoxic T cells. In addition, cytomegalovirus encodes several microRNAs, one of which binds to and prevents the translation of the cell's messenger RNA for class 1 MHC protein. And again, this would prevent viral proteins from being displayed on the infected cell surface, and killing by cytotoxic T lymphocytes would not occur. The latency can be in kidney cells for years. Reactivation of cytomegalovirus from latent state in cervical cells can result in infection of newborn during passage through birth canal. Similarly, cytomegalovirus enters a latent state in leukocytes and can be reactivated when cell-mediated immunity is decreased. Cytomegalovirus actually causes an immunosuppressive effect by inhibiting T cells. Clinical features of cytomegalovirus. There is a disease which is called as cytomegalic inclusion disease, and there is infection of fetus in this disease, and this is characterized by multinucleated giant cells with prominent intranuclear inclusions. I'll talk about these inclusions in lab diagnosis. Many organs are affected and widespread congenital abnormalities result. Infection of fetus occurs mainly when a primary infection occurs in pregnant woman. that is when she has no antibodies that will neutralize the virus before it can infect the fetus. The fetus usually will not be infected if the pregnant woman has antibodies against the virus. Congenital abnormalities are more common when a fetus is infected during the first trimester than in later gestational period, because the first trimester is when there is development of organs, and death of any precursor cell can result in congenital defects. Laboratory diagnosis of cytomegalovirus. You can take different specimens, urine, saliva, breast milk and semen. In microscopic examination, under histological staining, you can demonstrate cytomegalic cells, which are in the form of inclusion bodies. They are internuclear and they have owl's eye shape. If you can see this in picture, which is given at the top right hand corner, these are inclusion bodies. They are masses surrounded by clear halo. You can also go for electron microscopy. Isolation of a virus is a definitive technique. You can observe cytopathic effect from a culture in the form of multinucleated giant cells, and then is Schell-Weil's technique. It is coupled with the use of immunofluorescent antibody test, which can make a diagnosis in about 72 hours. Then there are various serological tests. There is a long list. We have also discussed this in general virology. Cytomegalovirus pp65 antigenemia test. Now this is an important one. This can be measured by detecting pp65 within blood leukocytes using an immunofluorescence assay. pp65 is a protein which is located in the nucleocapsid of cytomegalovirus, and this can be identified within infected leukocytes using fluorescent labeled monoclonal antibody test, which is specific for pp65. PCR can be performed in various tissues or body fluids, for example amniotic fluid. Epstein Barr virus. There are different antigens of Epstein Barr virus. Viral capsid antigen. This is commonly used in diagnostic test. Early antigen. It is produced prior to viral DNA synthesis. Epstein Barr virus nuclear antigen, which is located in nucleus bound to chromosomes, and it's also helpful in diagnosis. Lymphocyte determined membrane antigen and viral membrane antigen. Viral membrane antigen is also important. Neutralizing activities directed against this viral membrane antigen. Mode of transmission of Epstein Barr virus is through exchange of saliva. The saliva of people with a reactivation of a latent infection as well as people with an active infection can serve as a source of the virus. Pathogenesis. The infection first occurs in the oropharynx and then spreads to the blood, where it can infect B lymphocytes. Cytotoxic T lymphocytes react against the infected B cells. The T cells are the atypical lymphocytes. They are seen in blood smear, and this Epstein Barr virus remains latent within B lymphocytes. Clinical features of Epstein Barr virus. Infectious mononucleosis. It is characterized by fever, sore throat, lymphadenopathy and splenomegaly. Anorexia and lethargy are prominent. Hepatitis is frequent. Encephalitis occurs in some patients. Spontaneous recovery usually occurs in 2 to 3 weeks. Splenic rupture is associated with contact sports such as football, and it is a feared but a rare complication of splenomegaly. In addition to common form of infectious mononucleosis, there is another severe, often fatal progressive form of infectious mononucleosis that occurs in children with an inherited immunodeficiency. This is called as sex-linked lymphoproliferative syndrome. The mutated gene encodes a signal transduction protein required for both T cell and natural killer cell function. Epstein Barr virus infection is associated with several cancers, namely Burkitt's lymphoma, which is mostly in 5 to 8 years of age. It involves jaw, orbital cavity, and GIT tract and is in African children. Nasopharyngeal carcinoma, which is a cancer of epithelial cells and it is of Chinese origin. Thymic carcinoma in the USA. Post-transplant lymphoproliferative disorder, which is a common form of B-cell lymphoma. It occurs following both bone marrow transplants and solid organ transplants, and the main predisposing factor for this is the immunosuppression, which is required to prevent rejection of the graft. The lymphoma will regress if degree of immunosuppression is reduced. Then is Hodgkin's lymphoma and hairy leukoplakia, a whitish non-malignant lesion is there with an irregular hairy surface on the lateral side of the tongue, and again it occurs in immunocompromised individuals, especially in AIDS patients. So this is Burkitt's lymphoma, nasopharyngeal carcinoma and hairy leukoplakia. Epstein-Barr virus lab diagnosis. Isolation of virus is a definitive diagnosis, but it is expensive and time consuming. Then there are certain serological tests, immunofluorescent, ELISA complement fixation test. IgG antibodies indicate past infection, and rise in antibody titer to the viral capsid antigen or early antigen or Epstein-Barr virus nuclear antigen indicates current infection. Detection of Ig antibodies to Epstein-Barr virus capsid antigen in the serum. It's a screening test for early detection of nasopharyngeal carcinoma. Test for detection of heterophilic antibodies. Let's try to understand this with the help of this picture. The heterophilic antibodies formed in infectious mononucleosis agglutinate sheep or horse red blood cells in the laboratory. These antibodies do not react with any component of Epstein-Barr virus. It seems likely that Epstein-Barr virus infection modifies a cell membrane constituent such that it becomes antigenic and induces the heterophilic antibody. So this heterophilic antibody is defined as antibody that is detected by test using antigen different from the antigen that induced it. It is useful in early diagnosis of infection, that is by 2 weeks of illness, and it is not useful for past infection, and it is also not specific for Epstein-Barr virus infection. You can find these heterophilic antibodies in other infections such as hepatitis B and serum sickness. And monospot test detects heterophilic antibodies. The antibody titer declines after recovery. That's why it is not useful to detect the prior infection. Hematological tests include peripheral blood picture. Abnormal lymphocytes are there with absolute lymphocytosis. Atypical lymphocytes, they are enlarged, expanded nucleus, and with abundant, often vacuolated cytoplasm. So this is abnormal lymphocyte and this is the normal one. Summary. Epstein-Barr virus produces infectious mononucleosis and also produces heterophilic antibodies. Cytomegalovirus in immunocompetent adults produce heterophilic negative mononucleosis. So the picture is just like infectious mononucleosis, but there are no heterophilic antibodies. Thank you.